Welcome to Module 2. In this module, we will review different diagnostic strategies for post-COVID conditions, including POTS, vestibular syndromes and symptoms, post-exertional malaise, and brain fog. We will now discuss diagnostic approaches for POTS. It is important to approach POTS as a type of dysfunction within orthostatic intolerance, and recognize that there are many types of autonomic intolerance that can result as a post-COVID condition. As we reviewed in Module 1, the defining symptoms of POTS include an increase of heart rate greater than 30 beats per minute within 10 minutes of standing for adults and an absence of orthostatic hypotension. Once a patient has presented with symptoms that are suspicious for a type of orthostatic intolerance, it is important to consider broad causes for the patient's symptoms before attributing it to a post-COVID condition. After a thorough consideration of other contributing factors and laboratory workup, such as a CBC to test for anemia, looking for electrolyte abnormalities, thyroid studies, and a medication history and review for drugs that could be impacting the sympathetic drive, you can consider tests in the clinic and referring for further testing to evaluate for POTS. As we learned in Module 1, POTS is a type of orthostatic intolerance. As such, one of the diagnostic tests is an active stand or NASA lean test. The patient first begins lying down and their blood pressure and heart rate are measured at rest. Then, the patient will stand and their blood pressure and heart rate measurements are repeated at timed intervals in addition to recording symptoms. These tests are best performed under certain conditions. For example, it is ideal to test in the morning, as sometimes there are daytime variations in patients with POTS. Withhold medications that may interfere with autonomic responses, and avoid compensatory compression garments or excessive water intake. This slide is an example of a patient's results from a NASA lean test. SBP is the systolic blood pressure, DBP is the diastolic blood pressure, and HR is the heart rate. As shown, the sample patient has a baseline heart rate around 115 beats per minute at rest, and at 10 minutes after standing, their heart rate has increased and they have a marked drop in their blood pressure at the 10-minute mark. This patient did notably meet criteria for orthostatic hypotension as their systolic blood pressure decreased by greater than 20 millimeters of mercury within 3 minutes of standing. This was important to capture and demonstrated the importance of continuing testing for the entire 10-minute period. Additionally, the results of this test can show many types of orthostatic intolerance and helps differentiate between orthostatic hypotension and POTS. Another aspect that can be utilized in the diagnosis of POTS is autonomic function testing. This testing connects with the suggested pathophysiology that individuals with POTS may have an excess of sympathetic activation as discussed in Module 1. This testing can generally be performed at tertiary care centers. The autonomic function testing looks at different domains and how heart rate and blood pressure respond to different maneuvers that are meant to trigger parasympathetic or sympathetic responses. As a reminder, your body's parasympathetic responses are your rest and digest responses, and sympathetic responses are your body's fight or flight. For example, testing how your heart rate should respond to deep breathing is one of the parasympathetic domains. During a tilt table test, a patient wears a phenometer, which measures blood pressure and heart rate, and the patient is strapped to a table, which moves to change their position from horizontal to vertical. Tilt table testing is performed by having the patient lie horizontally for 5 to 10 minutes, bringing the table to 70 degrees, and then to upright. The phenometer measures heart rate and blood pressure throughout the test. In the figure on the right, heart rate is graphed in red and blood pressure is seen in black. There is a black bar on the time axis which denotes when the table was tilted upright. The figure on the top demonstrates a normal response where the blood pressure remains stable and heart rate increases slightly. However, the bottom graph demonstrates an abnormal response of orthostatic hypotension with a marked increase in heart rate and rapid decrease in blood pressure once the patient is tilted upright. This slide is an example of a patient who has POTS and was experiencing post-COVID condition symptoms and had autonomic function testing performed. This figure demonstrates an increase in both heart rate and blood pressure when the table was tilted upright. denoted by the black arrow. The heart rate increased significantly from a baseline of around 60 beats per minute to 120 beats per minute, and the blood pressure increased as well, demonstrating the proposed increased sympathetic drive as an etiology of POTS. We will now move on to discussing diagnostic tests important to consider with vestibular syndromes and symptoms in post-COVID conditions. In a prospective study, Tan et al. Utilized multiple testing techniques to evaluate both peripheral function, components within the ear and nerves, and central function, brain and spinal cord, of the vestibular system. To look more closely at vestibular symptoms, the following tests were utilized. VNG, or video nystagmography, which is focused more on nystagmus, which are involuntary and repetitive eye movements, which helps to differentiate between central and peripheral abnormalities in the vestibular symptom. VHIT testing is video head impulse testing, which is used to evaluate both overt and covert saccades, or rapid eye movements, and assess the vestibulo-ocular reflex. This reflex assists our gaze and balance even when our body is moving and performing actions. OVEMP and CVEMP look at otolith and vestibular nerve function and stand for ocular and cervical vestibular myogenic evoked potential tests. EEV is the European Evaluation of Vertigo Scale. It is a physician-administered questionnaire to assess for symptoms like illusion of movement, the duration, motion intolerance, and other qualities. Within all this testing, as mentioned in Module 1, Tan et al. Found that patients within the post-COVID conditions group demonstrated decreased high-frequency hearing, a difference in VNG values, asymmetric OVEMP and CVEMP findings, and low gain in VHIT. This overall demonstrated abnormalities in peripheral systems and did not demonstrate significant differences in central testing. This is an example of the EEV scale, which asks patients about symptoms at the time of the visit and for the previous 7 days. Other diagnostic questionnaires that are helpful include the Dizziness Handicap Inventory. When evaluating patients, it is important to consider that dizziness may not always present as a description that the room is spinning or a spinning sensation. Patients at times describe dizziness as feeling wobbly, being unable to focus, experiencing headaches because they're unable to focus on their screen, or new sensitivities to light or sound. Importantly, during the subjective report of the severity and types of symptoms, it's important to ask questions about the duration and onset of symptoms, in addition to triggers, as further referral and more emergent workup may be required. When assessing vestibular and ocular components with an exam, there are different aspects that can help us differentiate between central and peripheral causes of symptoms. Vestibulo-ocular reflex testing, or VOR, can be performed at bedside. If there were central abnormalities that did not correct with repetition of testing, then VNG testing would be the next step, and potentially an MRI with and without contrast to evaluate for structural abnormalities. For peripheral symptoms, VOR testing and passive movements of the head, while the patient affixes their eyes on a target, and vision testing are important components to be performed by a clinician. We can also assess balance impairments with physical therapy testing. It can help determine if patients are more visually dependent to maintain balance or more dependent on somatosensory input, and can help differentiate types of treatment. Patients will stand with their feet together with their eyes open and closed for 30 seconds on both a firm surface and a foam surface to see if there is lack of vestibular input. For example, an abnormal result would be if a patient requires additional support on the foam surface and needs to expand their gait in order to stay balanced with their feet together. We will now review how to assess and diagnose post-exertional malaise. Cardiopulmonary exercise testing, CPET, detects changes in mitochondrial function and graded exercise. This helps detect small changes in heart, lung, and metabolic functioning, which helps show the source of exercise intolerance and impaired recovery. Findings have suggested that patients with post-exertional malaise have a potential premature ventilatory anaerobic threshold. This means that patients who suffer from post-exertional malaise are not able to utilize the oxygen they are breathing in a timely manner for metabolism in settings where they require more energy breakdown, like exercise. Patients with post-exertional malaise prematurely switch to anaerobic metabolism, potentially contributing to earlier fatigue. The DePaul Symptom Questionnaire is a self-reported questionnaire that can be easily performed in the clinic that measures the frequency and severity of fatigue exacerbations over the course of 6 months. This questionnaire was validated specifically for post-exertional malaise. We will now discuss the diagnosis of brain fog and other cognitive impacts secondary to post-COVID conditions. As a reminder, brain fog is defined as a persistent cognitive impairment in attention, concentration, executive functioning, or information processing. These are examples of testing which can help identify different characteristics of brain fog like memory, attention, language, processing, and executive functioning. Administered testing includes the R-bands, BNT, and TMT. Patient self-reported testing includes the MMQ, Latrobe Questionnaire, and Mental Fatigue Scale. Other important aspects during evaluation of cognitive impairments includes patient-reported outcomes on the right track as to how patients are doing over time throughout clinical visits and assessing what domains they feel are important to continue to address. This slide is an example of the Multifactorial Memory Questionnaire, or MMQ, a patient-reported questionnaire and scale that evaluates functionality and how patient impairments impact their day-to-day life and the frequency of these impairments. These tools help to identify what strategies patients may currently be using to assist with cognitive impairments already, or areas that can be bolstered. This is an example of questions in the Latrobe Questionnaire, a patient-reported test that evaluates communication across a wide area of cognitive function. As we have discussed aspects to help diagnose post-exertional malaise and brain fog, it is important to note that both post-exertional malaise and brain fog can be part of the diagnostic criteria for ME/CFS, or myalgic encephalomyelitis chronic fatigue syndrome. This slide reviews the core criteria for patients to meet in order to diagnose ME/CFS.